Good morning, everyone, and welcome to my YouTube channel, Pain Free Partha. And most of my slides can also be downloaded free from my website, painfreepartha.com. So today's topic is about mitral regurgitation. I'm going to talk about the pathophysiology, the insights of MR, what is happening in MR. I'm not going to detail the anesthetic techniques. I'm going to give the tips of successfully managing these cases. What is mitral regurgitation? It is caused by retrograde flow of blood from the LV to the LA. From the LV, it normally has to go to the aorta. But if it leaks to the left atrium through the mitral valve, then it is called mitral regurgitation. Sometimes they call it as mitral leak. Sometimes they call it as mitral incompetence. These things have gone and regurgitation has stood the test of time. Now you see, any valve will allow flow from here only, one side. This will not allow flow from here. So that is a valve. If it flows from here also, then it becomes a regurgitant valve. Similar to this is a mitral valve. MR is the most common valvular abnormality, and it prevalence increases by age. Now you see traces of MR. Mild MR 8.9%, which becomes 28.1%. It is moderate is 0%, becomes 11 point, and men and women. So a significant increase with age in the incidence or prevalence of MR. MR develops if the mitral valve reflex do not sufficiently cover the mitral orifice area throughout the LV systole. Now ventricle is contracting and it is ejecting through the aorta. And if there is any problem with the mitral valve, throughout it has to control the flow through the mitral valve. If it is not possible, then it becomes a mitral leak. It is commonly classified as primary MR. Primary MR means there is a leaflet pathology. There is a problem in the leaflet, rheumatic origin or something like that. Secondary MR means there is a myocardial pathology. The valve is actually normal. Structural damage of the valve, rheumatic, papillary muscle rupture, mitral valve prolapse, congenital, infective endocarditis, or primary valve problem. Now, if you have an ischemic cardiomyopathy or a dilated cardiomyopathy, then the valve leaks, then it is a secondary MR. Now you see there is a valve defect. So instead of LV going out to the aorta, it leaks here. But here the LV is remodeled like this, dilated cardiomyopathy. So the annulus is stretched. So there is a leak here. So this is what is called a secondary mitral regurgitation. This is different from a different classification. Now you see normal mitral valve is like this. And this is a mitral valve prolapse, the ruptured carda tendini, and the whole this thing is dilated. Here you can see the mitral annular dilatation. This mitral regurgitation can also be classified. Now what I have done, we have done primary and secondary. Now there is a different type of classification. When the symptoms are acute, that is an acute MR. When the symptoms of insidious, then you say it's a chronic mitral regurgitation. So if there is an heart attack or infarction, papillary muscle have ruptured, and the patient develops a acute MR, this is acute MR. And endocarditis, acute MR. Now you see prolapse, congenital, radiation, rheumatic, all these things, they develop an insidious onset and progress. Then we can call it as chronic MR. What is the pathophysiology? Mechanism, severity, and acuity. That is what is the problem. So it depends upon how severe it is, how acute it is, and this differs vary the pathophysiology. Now we go to acute MR. There is a papillary muscle rupture or myocardial infarction. The LA is not ready to get the regurgitant volume. The LA is not dilated. It's a normal left atrium. Suddenly patient develops infarction. Patient develops infective endocarditis. Mitral valve is a problem. Sudden regurgitation. So the LA is not ready. So patient will develop, go backward symptoms, and they get into pulmonary edema very fast. So here is a normal LA. Now if you go on regurgitation, the LA will go on to have a back pressure and the patient will develop acute pulmonary edema. The regurgitant volume enters LV again. This is more of a chronic problem. Even though it acute also it happens. MR causes LV volume overload. The increased preload to increased sarcomere stretch and slowly because it contracts well. Because it's a catapult theory, Frank Starling mechanism. As you pull the catapult, leave it, the arrow will go much. So that is what is called the Frank Starling. The sarcomere length is stretched. LV gets more blood. So again, it will contract better. And this is what happens. So when it is sudden, you get pulmonary edema. Left atrial pressure increases and you get pulmonary edema. When there is an insidious onset, there is more flow here, some flow here, and comes back again. The LV gets dilated. There is an eccentric LVH. The isovolumetric contraction phase will decrease. The contraction phase is there, no isovolumetric, will decrease because the volume decreases. As soon as in systole, the mitral valve should close and should not allow any leak. Now this is not happening. Now there is some blood going here in systole. So it is not isovolumic. So isovolumic is shortened. So there is a slow things. LA is dilated and can cause, the problem is LA dilatation can cause thrombus and LA dilatation can cause AF. So if the transmural pressure increases, if the radius increases, sometimes the wall tension of the LV will increase. This is what I have told. See here, the isovolumetric contraction phase is decreased. But here, the volume is less. In chronic, again it comes back. The volume, end diastolic volume is increased. So again it pushes back, but still little less. That is what is the acute MR and chronic MR difference. Slowly it becomes compensated, transitional, and here we can see the decompensated. Up to LV volume of 140, it cannot do the things. Here it is stress. The isovolumetric contraction phase is shortened. That is what we told. Blood is ejected into the low pressure LV. Because of the dilated component, LV accepts increased diastolic volumes. They may think that this diastolic function is enhanced in patients with chronic MR, but this is not so. Dilatation of the left heart chambers permits LV filling at low pressures. Chamber enlargement dilates the mitral annulus, increasing the effective regurgitant volume. Now you see ventricle contracts. It has to go to the aorta, but it goes to the LV. The LV is slowly dilating. The more blood comes again back to the LV. So there is a sarcomere stretch. Contract is more of aorta, more again to the LV. LA dilated. So it progressively dilates the LA, progressively dilates the LV, so that again the mitral annulus. First it was primary MR, some rheumatic disease. Now slowly MR is increasing the own MR and the LALV dilate to cause a secondary MR in these cases. That is what is called begets, means worsens. Mitral regurgitation begets mitral regurgitation. Acute MR, backward symptoms immediate, but chronic MR, because slowly LV dysfunction starts, the output is not much. So the forward symptoms may predominate like fatigue and all. And these patients get delayed, maybe 3-4 years to get symptoms. But it is hardly a few hours. All the backward symptoms can come also in chronic. When the LA dilated, when it goes back, pulmonary hypertension develops, all these things. Yes, this can happen even in chronic MR, but that progress is insidious. What are the clinical findings now? Acute MR, acute dyspnea, acute pulmonary edema. In chronic, there may be fatigue. If the pulmonary hypertension develops in chronic MR, all these things comes. Widening of pulse pressure, apical holosystolic murmur with radiation to the axilla, and if there is any problem with RV function, dependent edema, jugular venous extension, and there may be a displaced apical impulse. That is what we told. LV is dilating, apical impulse is dilated. Where we saw in mitral stenosis is tapping apicals. First heart sound is what? It stays in the fifth space. But here the apical impulse is pushed outwards because the LV is dilated. X-ray chest may show a cardiomegaly. ECG will show LVH, left axis deviation, left atrial dilatation, and sometimes atrial fibrillation. How severe is our MR now? Now we know there is an MR. If the regurgitant fraction is less than 30% or more than 50%, if the regurgitant orifice is only 0.2 or it is more than 0.4, if the regurgitant volume is tucked per beat 20 ml only, per beat 60 ml goes. So regurgitant fraction is 30%. Regurgitant orifice is less than 0.2 and regurgitant effective total volume per beat is less than 30 ml. Then we say all these things are mild MR. There are a lot of other things. 2D PISA, proximal isovelocity surface area. Whatever we see, PISA, whatever it is, we are finding out the area. Now we see here, this distance should be, the regurgitant area should be around 4 to 5 millimeters. And this VC, this area should be more than 0.4 square centimeters to be thick. This is VC, we saw vena contracta, which is more than 7 millimeters. If there is a pulmonary hypertension, if there is a ventricular dilatation, if there is an LV dysfunction, all these things put into very severe mitral regurgitation. We know the regurgitant volume, the regurgitant area, the valve area, all these things. If it is going to be more than this ml, more than 50% of the regurgitant fraction, so they are put into severe. But if you have at VC level width more than 7, if there is a pulmonary hypertension, if the LV is dilated more than 7 centimeters, and if there is an LV dysfunction, all these things point to severe mitral regurgitation rather than the first three ones which I told. They are there, but still we need to confirm with these things. So what we are important, mind is set for regurgitant volume. 100 ml is going to the aorta and 30 ml is going to the thing out of which. So 30, 70. So what should be done to decrease this? This is our aim. So afterload reduction, LV contractile state. Now we know flow through an airways vary by the square root of the pressure gradient. Yes, the problem is if the flow increases, the pressure gradient increases, but it is only root of it. So pressure gradient, if you are thinking, only the root it will increase for a variation in flow. That is what is called Torricelli's law. So flow increases 4 times, the pressure gradient will increase by 2 only, square. So we cannot exactly put our mind into the pressure gradient only. The orificial area is not static, it changes. And we know the Coanda effect. Sometimes it will regurgitate through one wall and the other things is not there. Transesophageal echo, stress testing, cardiac MRI, class catheterization, and biomarkers like BNP may give a clue. And catheterization is not usually done after echo as dominated the proceedings. But cardiac MRI can tell what is the volume and what is content. Probably a regurgitant fraction, it can tell. Now, what is acute MR treatment of the cause? Give diuretics, vasodilators, IABP, inotropes to get the things up. Acute pulmonary edema, we may need CPAP. A chronic MR needs beta blockers, ACIs, diuretics, and correct AF. So we give ACIs because we want to decrease the afterload. What is that? Aortic pressure, afterload. So ventricle contracts with a lesser pressure, against a lesser pressure. More blood will go into the aorta. Less blood will go into the atrium. So we want diuretics, aldosterone, correct AF. We know when is it MR is primary or secondary. If the LV dysfunction is between 30 to 60% of EF, not severe LV dysfunction. And if severe MR, yes, surgery matters. Now, if there is a history of LVF, non-cardiac surgeries, we go because we are more bothered. I am very interested in ruling out anemia because whole symptomatology may change if the hemoglobin goes up from 9.5 to 11.5. ECG is there is any ischemia. Clinical signs of LVF or RVF. All these things matter. For example, JVP, edema, congestive hepatomegaly, RVF is itself there. If there is an LVF, bilateral Krebs is there. All these things matter. Severe MR does not need loud murmur. That we should know. MR is severe, loud murmur, nothing like that. Now you see a dilated LV. EF is usually 70%. Don't think. People say heart, cardiac opinion and echo. EF is 70%. Normal. Now here, even if the EF is 60%, you have to think. In mitral regurgitation, EF is usually 65 plus. That is what is very important. So there, if you have an EF less than that, then we should think there is some LV dysfunction. Even 55 is sometimes LV dysfunction in MR. Now, what are the hemodynamic goals? Fast, full, and forward flow. Full means preload is adequate, good volume. Fast means the rate is around 90 to 100. It reduces the filling time of the LV. This helps when we contract overloaded ventricle and encourages forward flow. Yes, but if the MR is associated with an ischemic heart disease, we should be careful. We should be titrating between 90 to 85 or something like that. We should also take care of the ischemic heart disease with relation to tachycardia and MRs better with relation to tachycardia. Now preload we can pour. Now we can pour little and it goes ICEC, SVC, so that preferable erring on the higher side. Now you see, if the afterload is decreased, LV can push fast. Easy here, rather than LA. Now LA, for example, now LA is 10 millimeters pressure and aorta is 25. Example, I'm telling. So LV tends to push blood here because it's 10, it's 25. Now if you decrease the afterload and it becomes 12, it is relatively easier also here. So if it pushes more blood here, less blood is going. So the regurgitant fraction is less. That is what we should keep in mind and get the forward flow. So more blood, because if we keep hypovolemic, less blood will come and less blood will go. So you pour preload air on the higher side. Pulmonary vascularity, we know slowly PVR is increasing. So hypoxia, hypercapnia, acidosis, nitrous oxide, question mark. In acute MR, inotropes, inodilators like levasimentan, yes. But in chronic MR, their use is questionable. Now we go to cardiac grid. Preload, already we have told, normal or slightly increased. Heart rate is slightly increased because we give decreased filling time so that it is decreased. This thing is there. LV is not filled up like. SVR is decreased so that the forward flow to the aorta is more. Pulmonary vascular resistance don't increase. Already there is a problem. So hypoxia, hypercapnia, acidosis, nitrous oxide, come down. Contractility, chronic MR, yes, we need to be bothered less. An acute MR, yes, dopamine. Afterload is SVR decrease. Now again I'm telling pour much here. And contractility is not that much. Query. Pulmonary vascular resistance is decreased or normal. Heart rate is on the right higher side. Now afterload is decreased. So more blood will go here. Less blood will stay in the ventricle. Not much of contractility is needed. PVR is already high. So don't cause increase in PVR. Types of anesthesia. It doesn't matter if you maintain the grid of cardiac anesthesia. Neuraxial anesthesia is well tolerated because it vasodilates. Afterload decreases. But that still preload also decreases. So we may need to be careful. Vasopressors in titrated doses. Maintain the grid. So in pregnancy, we know pregnancy causes heart rate to increase, systemic vascular resistance to decrease, and volume increases. All these things, MR is tolerated better in pregnancy. So the most common indication to call the surgeon before any cardiac surgery is severe pulmonary hypertension. LVF is 30 to 60. Less than 30 means the prognosis is a little less. We have to think about before doing AR. Now, degenerated valve disease, severe MR, think of the surgeon. Prognosis is little query. If you have severe LV dysfunction, the pulmonary artery pressure is itself 50, causing an RV dysfunction. Age is more than 75 years. Your aortic or mitral valve replacement may not be that good. So we know the incidence in age increases up to 23%. Types and causes, acute and chronic in one side. Another thing is primary and secondary. Pathophysiology is as soon as it contracts, systole does not close the MV completely. LA goes back and LA comes more volume in the LV and it contracts well to push in aorta and again go into the LA. More volume comes back. So mitral regurgitation, slowly LA dilates, LV dilates. The first thing which happens to maintain the cardiac output. But after some time, the LA pressure increases. Slowly it goes into pulmonary hypertension. Slowly it goes into RV dysfunction to get our RV failure signs. These are all in chronic. But in acute, the LA is not ready. Acute pulmonary edema, flash pulmonary edema is the cause. If there is going to be an infarction associated papillary muscle rupture and acute MR. So severity, I already told, severity clues are there. We see more than 7 millimeters. The regurgitant fraction is more than 50%. And the LV diameter itself is more than 70. And if there is an incidence of pulmonary hypertension, severe LV dysfunction, they are all severity. Surgery, yes, indicated I have told, non-cardiac surgeries maintain the grid. Err on the side of increasing preload. Heart rate is at 90 to 100. SVR is decreased. Don't increase PVR. These things have to be kept in mind before anesthetizing these patients. Visit my site www.painfreepartha.com for slides and visit my channel Pain Free Partha for more than 50 slides of anesthesia, and also you can go for some MBBS classes. Thank you all.